right, folks, here we go. Another live and interactive positive aging community discussion. Really excited about today's topic. And but before we dive into that, let me go through a little housekeeping, especially for those that may have never been to one of our discussions before. The first thing that you need to know is that these discussions are live and interactive, and you can ask questions, you can make comments, you can share resources. Now, I say that with a little asterisk because I've noticed lately that our YouTube and our LinkedIn audience has been growing. And so if you're on either one of those platforms, it's best to get over onto our Zoom platform where you can interact with the audience. But there's three ways. Number one, you can throw questions, comments, or things that you want to share into chat. The other way you can do it is use that little Q&A button at the bottom of your screen, type in your question there. And then the third is that you can just raise your virtual hand. We'll open up your mic and camera, and then you can ask a question verbally if you prefer to do that as opposed to typing. So we hope you sit back and enjoy and participate as much or as little as you like. Also, you don't need to worry about your mic and camera suddenly coming on. The only way that can happen is that if you give me permission. These discussions are brought to you by the Positive Aging community and as well as Sourcebook, and we're able to do that free of charge because of the support of our Positive Aging community champions. Just so happens that the Inova Parkinson's and movement disorder is one of the Positive Aging champions, and we're going to be meeting one of their doctors here today. But you can find all the champions and hundreds of other resources on our website at proaging.com. You can order free copies of Sourcebook, but today's discussion is going to be recorded, and you'll be able to see it on the left-hand side of the screen under recordings this afternoon. And then on the right-hand side, you can see what we've got coming up, the discussions that were coming up. And let me just go through a few of those because, believe it or not, we've got a discussion every day of the week this week. I don't know if I've ever done it quite like this, but tomorrow we're going to be learning about a new approach to home sharing. It's this innovative company called Perch Houses that has created shared housing for women 55 plus, and it's below market rate if you compared it to market rate housing in the regions that they are doing this. That's going to be a great discussion because home sharing is a growing trend. Then on Wednesday, we've got the author of How to Live Forever, a guide to writing the final chapter of your life story. We'll be talking a little bit about advanced care planning, death and dying, and really what kind of legacy we want to live. And then on the topic of movement disorders, we've got another discussion this week on Thursday, September 28th, and we're going to be talking about primarily about exercise, why exercise is important with Parkinson's. And last but not least, we are going to have a discussion on Friday that we're going to learn about life expectancy calculators, how they're used, and what we need to know about those. So we've got quite a few interesting discussions this week on a wide variety of topics, but what we are concerned about today is our discussion today. And I'm really excited that to have another physician today from the Inova Parkinson's and Movement Disorder Center, Dr. Abigail Lawler, who's going to share with us information about memory and movement disorders and are these normal parts of aging. And so I'm delighted to have Dr. Lawler join us on stage because I tell you, we do a lot of discussions on movement disorders, and it's especially with Dr. Falconer, we've had him on many times, another physician in the same practice. And it seems like the discussion often migrates to the association between Parkinson's and or movement disorders and dementia. And so I'm hoping today that we're going to learn a little bit more about those connections and what they mean. Dr. Lawler, really excited to have you here today. Before we dive into learning more about this relation between memory disorder and movement disorder, let's get to know you a little bit better. Tell us a little bit about your background and what led to you practicing in this area.
Thank you. Thank you, Steve. Thank you for having me today. So yeah, I am not new to the area, even though I just started working for Inova Neurology coming about almost quite just about under a year. But I did all of my training at MedStar Georgetown. So I was there for not only residency, but I stayed there for fellowship training in movement and memory disorders, as well as dysautonomia. And then, due to family, moved out west for a period of time, about 5 years I spent in San Diego, and just now getting back to the area to kind of where it all began, to practice in Virginia.
Well, tell us so have you always been practicing in neurology and movement disorders, or how did you, and was this what you dreamed about when you were in med school as a young doctor?
Yeah, not all of us, I'm sure, have taken the same path to get here. I actually started in general surgery, believe it or not. And I just found, even though I had a love for surgery, I also had a love for the brain and central nervous system and some of those complex diseases. And so I was really torn, but I ultimately chose to go into a neurological field because I think it best fit with my long-term goals to have a family. So ultimately I chose neurology. And within that, I think we always have that mentor that really inspires us. And it was Fernando Pagan, who is the head of movement disorders at Georgetown, that really inspired me to want to get involved and taking care of patients, not only with Parkinson's, but other movement disorders. And also just seeing the impact of how you can really help these type of patients with these conditions, and the influence you can have, and how beneficial not only is for the patient, but it's very gratifying to see people actually do well and get better.
Well, I will tell you, I mean, your practice has impacted my family, and it is gratifying because both my mom and my cousin had severe tremors and just thought there was nothing they could do about it, and they'd figured out how to live their life. And it's because I was on a lecture with Dr. Falconer that they have both connected. And it's, I mean, I kind of tear up when I think about it, because it's sort of like for years they had been challenged with really modifying everything that they did so that they wouldn't spill a Pepsi on their pants while driving into to work. Or my mom would be very cautious about doing any kind of like a tea party or something like that. And now I'm pleased to report that they're both, have a lot more energy, and it really made a huge impact.
Yeah, and that's the other thing, is a lot of people don't realize that there are options. There is a better way. Sometimes we see physicians or even people that are specialists, and we think we're getting the best care, but it really pays to kind of shop around and make sure you are seeing a specialist specific to the type of problem that you have, because I think it really can make a big difference in the recommendations you get and the treatment options that are offered to you. And that goes without saying, especially in Parkinson's. I know that maybe a lot of people don't understand out there that there are a lot of neurologists practicing. Some of them are what we call general neurologists. So they don't really have any specific subspecialty, or maybe they haven't done any training beyond just their neurology residency, and they see all kinds of different, problems, neurological problems, and they may have an interest in Parkinson's. It may say that on their website that they do treat patients with Parkinson's, but that by no means that they are a specialist in Parkinson's. And so what it means to be a specialist in Parkinson's, that beyond your residency in neurology, you have done additional training in movement disorders, specifically trained to take care of patients with Parkinson's, not only diagnose those patients, but offer them a variety of different treatments beyond the standard treatments that may be offered to you if you just see a general neurologist. So that can be very confusing, because sometimes people think they're seeing a specialist when they're not,
Man, well, I'm really glad you brought that up, because today we can talk, folks. You've got Dr. Lawler here, and so feel free to ask any questions related to movement disorder or Parkinson's or what have you. But today I'm really glad that we're going to try to focus on memory and movement disorders and the relation between the two of them. And as you were talking, I was struck by the fact that there's movement disorders that and under that umbrella, Parkinson's is there, but that's also essential tremor and other things that I don't know about. Just like in memory care, we have, dementia, and then you've got various different types of dementia, of which Alzheimer's is, the most common one that we hear about. And I think the thing that I wanted to address as well is diagnosis of both of these, memory disorder and movement disorder, is so essential. And I think you kind of hit the nail on the head there, is that, a general neurologist might not necessarily be giving you the best diagnosis if you are concerned about your diagnosis and what have you.
Yeah. And some people, they're not concerned, and maybe they should be, right? I can't tell you how many times I've seen patients that were seeing, a general neurologist, or even, had conversations with their primary care doctor about issues they were having, and told, you don't have Parkinson's. I see that you have tremor or whatever, but that's not Parkinson's. And then eventually they get to me and it's not the case. They actually do have Parkinson's. And that's very upsetting. Not only, I get even a little bit worked up about it when patients are being misled, and no one's doing that intentionally. Certainly, most physicians have the best interest at heart for their patients, but it just goes to show you that experts are expert for a reason, and it does not hurt to get a second opinion. If there's any doubt about, your diagnosis, or maybe you're just not where you want to be in terms of control of your symptoms, and you're looking to get answers, that it's always a better idea to get, someone else's opinion on what's going on.
I love it. Okay. We're going to dive into memory and movement disorder, but I already got a question that came in, and it's not related to either, but I want our audience to be,
active, involved.
They tuned in. Yeah, exactly. So what this person says is, I'm in the sandwich generation. My question is whether a child with primary complex motor stereotypes movement disorder is likely to develop Parkinson's. Can you provide some feedback on that?
I mean, that's a tough one, because I'm not exactly sure what they're talking about. Like, if that was their diagnosis, or do they have like a tic disorder? Like, what exactly are we talking about here in regards to that specific patient?
Okay, great. Well, if whoever asked that question, if you want to elaborate a little bit more, I can throw that to Dr. Lawler. However, I will say, because I've had Dr. Falconer on here with some of these interesting questions, a lot of times it really is a good idea to reach out to the practice and get the specifics. And of course, especially with a child, I can only imagine that is something that is very important to you and your loved ones. And Okay, well, we opened the door here. So Dr. Lawler and audience, I promise we're going to get to memory care and its relation to movement disorders. But Catherine says, will and can Tourette syndrome with motor tics develop to be a later diagnosis in Parkinson's?
Yeah, usually there is not a connection there. So that is a separate, totally different type of movement disorder. It usually in kids, it can progress into young adulthood, and usually it will go away on its own, but sometimes it does persist. And sometimes as adults, we can develop tic disorders. So the treatments for tic disorders are totally and completely different than Parkinson's. And that I'm not aware of any type of increased risk with that type of disorder and a Parkinsonian disorder.
Now, is like tic disorder and Tourette's, is that treated under your practice?
Yeah, absolutely. Yes.
Okay.
Yep.
So there are treatment plans that folks can go by.
Yeah, and if you are a child, so you're under the age of 18, you should really see a pediatric neurologist
Okay.
as opposed to an adult neurologist. There is a distinction, and you're better served to see the pediatric neurologist because there's a separate set of dosing that comes with a lot of medications and kids as opposed to adults. So
Okay, and what's interesting that was actually a different question from Catherine. Now, the person that asked the first question, she's elaborating and she says, the child has movement disorder that is called primary complex motor stereotypies, which is not well known in neurology, no tics and no Tourette's. So that's but I would say to this person, reach out to Inova. We'll make sure to actually, Sonia, if you can put the contact information in so that somebody could reach out and make an appointment. I think
yeah, I mean, it sounds like a non-specific involuntary motor disorder that somebody has given them that diagnosis, and it may be a diagnosis of exclusion, whereas meaning that they have ruled out other things and haven't really been able to figure out what they have, so then they get labeled as something like that. That's what I'm thinking. I'm not aware of an increased risk of that condition in Parkinson's. There are some involuntary movement disorders in children that are levodopa responsive, meaning they respond to the same medications that we classically give Parkinson's patients, but that is not one of them that I'm aware of.
Okay. And she says she was diagnosed by Dr. Harvey Singer at Johns Hopkins. And I think it's always, I think that you would agree, Dr. Lawler, is having multiple, opinions is not a bad thing.
Yeah.
And so okay, we're going to get to this, but we got another question here. And that is, I'm in my 60s. I've had essential tremor for more than 20 years. My neurologist does not recommend medicine. Are there any exercises or other things I can do to minimize the tremors, including diet? I exercise regularly. The tremor is worse when I'm stressed. And I've listened to Dr. Falconer a few times, so I'm curious at your response to a question like this one.
Yeah, I mean, it's true. So essential tremor is one of those conditions that can be very disabling. It does not need to be treated unless it is bothersome to the patient or, impairing the use of your hands or your ability to do your activities of daily living. And you always have to weigh the benefits, the pros and the cons of starting a medication, because there are potential side effects. Even though there might be some benefits of tremor reduction, there are potential side effects. And so what I find with patients with essential tremor is you just weigh all those pros and cons and kind of make a decision together whether you think it needs to be treated or not. But there's nothing from like a homeopathic or physical lifestyle change that can really make a difference in tremor. I mean, certainly like stress reduction, but sometimes that's out of our own control, but even if I have a patient well controlled on medication, if I throw them into a stressful situation, those tremors are going to come out and it's going to not even seem like they took their medicine. So you just have to be mindful of that. What I will say is that patients with essential tremor do have a 30% increased risk of converting over to having Parkinson's. And so you should be evaluated for Parkinson's at least on an annual basis.
Okay, great. And as I don't know if you heard the person that asked that question, if you heard at the beginning, I shared the experience that my mother and my cousin went through, and they're on medication. It's not a heavy dose, but they will tell you it was life-changing to them. And I think it might be one of these things. We do want to live, and we want to be careful about being overprescribed. However, like Dr. Lawler said, there's nothing that says that you can you could go off the medication if it bothers you and go back to, the other non-medicated treatment plan. Okay, man, we're going to get to memory disorder. Last one, and then I promise, we're going to have a little chat about this, and then we'll get to the rest of the questions. Jean asks, is vertigo considered a movement disorder?
Not really. So vertigo is that sensation sometimes that the room is spinning. Also, it can be a little bit confused with the symptom of dizziness or lightheadedness. It can be an inner ear problem. So there are issues with the ear that can lead to those type of symptoms. It also can be one of the first symptoms if somebody is having a type of stroke. Also, it can be seen with a blood vessel problem in the brain. So there's something called vertebrobasilar syndrome. So sometimes people can get a sense the room is spinning or dizzy lightheadedness feeling when there's narrowing of the blood vessels in the brain. So a number of different conditions can lead that, and certainly always medication side effects, right? Those can be the underlying problem or source of the issue. But no, it's not actually a movement disorder. Technically, patients will see neurology frequently for this problem. They also may be referred to an ear, nose, and throat doctor for that problem.
Great. Okay. We got through our first pile of questions there, and we'll take many more. But Dr. Lawler, tell us, what is the relation between memory and movement disorder, and what are some things that we need to know, especially for the many times it's a question that comes on these discussions. It's the relation between Alzheimer's and Parkinson's.
Well, it's definitely an interesting one, and a great topic to bring up, because there are a number of specialists out there, like myself included, that believe that this is really just all one disease. If we're talking about, Alzheimer's and Parkinson's, and it's a spectrum, right? You've got Alzheimer's disease at one end of the spectrum and Parkinson's at the other, and somewhere in the middle is something called Lewy body disease or Lewy body dementia. And the reason we think that is from evidence from post-mortem autopsies on patients that were end-stage Alzheimer's, end-stage Lewy body, and end-stage Parkinson's. What we have found through autopsy and looking at the brains of these patients is that there is a mix of abnormal proteins in the brain throughout the brain. And a lot of the brains look very similar in the end stages. And so some people believe the reason why we're seeing that is that whatever abnormal protein accumulates first, that sort of defines how the disease is going to start, and may also lead to the set of initial symptoms that leads to an initial diagnosis. So let's say it's alpha-synuclein, the underlying protein that's implicated in Parkinson's. Maybe that starts accumulating first in the brain and the symptoms start looking like a Parkinson's patient. Or Alzheimer's, let's say maybe amyloid, the underlying protein implicated, and then that starts accumulating first. And depending on the part of the brain affected, you start to develop more memory issues, initially, and it leads the patient down that path with their physician and getting diagnosed. But no one's doing brain biopsies on these patients to get to a diagnosis. That just really wouldn't be worthwhile. But that's why we believe it may be a spectrum. And then you get these people that kind of fall in between, right? They don't quite maybe fit all the criteria for this diagnosis over here, and maybe not this one over here. And you get something called Lewy body disease, where, in order to meet criteria for a diagnosis of Lewy body or Lewy body dementia, there's diffuse Lewy body disease. There's different names for the same thing, which really it's an atypical form of Parkinson's. But in order to meet criteria for that diagnosis, you have to have memory problems within 2 years of onset of a motor problem. So either the motor symptoms come first and 2 years later, or within those 2 years, you get memory issues, or the memory issues come first and within 2 years, you start to develop motor symptoms.
Now,
So
do you see in the patients that you're working with, do you see that there are more that start with motor or more that start with memory, or is it just pretty much a 50-50 random split?
well, right now I'm seeing a ton coming in with problems with memory. I mean, all ages too. And in part, the reason why the uptick in the consultations for memory loss is because of our aging population, right? Right now, for the first time in history, we have the largest group of seniors in that age bracket where memory disorders are prevalent. And so we're seeing more and more of that. And then also to people that have a strong family history and they're starting to get just a little bit of short-term memory loss. And so they're being proactive. And today, our patients are very proactive, right? In the age of the internet and social media and all of the things at our fingertips, people are very educated, and they've gotten a base knowledge themselves just by doing their own research before they ever come to see a physician. And that's a good thing, right? So now we are catching things earlier and earlier in patients. But yes, I mean, to answer your question, mostly what I see is the initial symptom is some sort of memory change. And when I use the word memory, I'm kind of using that loosely because cognition, there are many facets to cognition, and memory is just one little slice of that, one little piece of the puzzle.
Okay. And I can only imagine how challenging and frustrating this might be to start with memory cognition problems and then the movement follows. The patient is already in a really challenging situation, and why is this happening to me? Well,
it also can be a surprising twist and turn of events when you come in thinking you have one problem or one diagnosis, and by the end of my evaluation, I'm telling you there's something else going on. I have seen that a number of times. And it's because the way we're trained is that we have a number of screening questions that we ask. Because when someone comes in with a complaint of memory loss or short-term memory problems, what have you, there is a whole differential, right? There's that's at the top of the umbrella, and there's all these things underneath the umbrella that we're making sure the patient doesn't have symptoms of. So we're going to ask a ton of questions on that initial visit. And then the whole time you're sitting there answering our questions, we're using our eyes to kind of see what you're doing, right? Your normal mannerisms sitting in the chair. Are you nervously ticking along with, moving an arm or a leg or tapping your foot or your leg? We're paying attention to all these things. We're trained to do this. And then when we do our physical exam, we have different tactics that we will use, aids of distraction, if you will, to kind of get the best exam, right? Because sometimes if someone knows what you're looking at, they tend to perform, so to speak. And it can kind of hide the real exam. Yeah.
In the case of my mom and my cousin, yeah, when you're living with a movement disorder for so many years, you figured out how to kind of hide your hands and do things of that nature. And what my mom said when she went on the treatment plan from Dr. Falconer is she had a tremendous amount of energy. And she ties that to the amount of energy she was exerting in terms of disguising her movement disorder. She didn't even realize because she had been doing it for so long.
So tremors can actually, uncontrolled tremors, it's like a workout in your chair without trying to work out. You actually expend a lot of energy and burn a lot of calories just sitting there, tremoring away. And then, yes, like you said, the energy you expend to try and cover it up and hide it and stop it. A lot of energy is spent doing that.
Oh, and Sharon asks, who is Dr. Falconer? Since he's your colleague, Dr. Lawler, if you want to share his role in your practice. And then what I'm going to also do is I'm going to pull up and make sure that I put a link in chat to all the discussions that we had with Dr. Falconer prior to this.
Yeah, so Dr. Falconer, a colleague of mine, he's also the director of our movement disorder program at Inova. We are old buddies. We both trained at Georgetown together. He was 1 year ahead of me. He also did his fellowship there in movement disorders with Fernando Pagan. So Yeah, so he, when he graduated, he split off, him and Dr. Sean Rogers, another colleague of mine in our movement disorder program. The two of them started Inova right out of their fellowship at Georgetown.
Great, great. So hopefully that helps, and I'll drop these I'll drop these recordings into chat. So it's interesting that we're talking a lot about diagnosis, and I'm glad, because last week we had we had an amazing discussion with Sam Simon, who is known as Dementia Man. He was diagnosed with dementia, and he wrote a play on the experience that he went through. And one of the most frustrating experiences that he went through was the diagnosis, because when he first went to his internal medicine doctor, oh, Sam, what you had said earlier, oh, Sam, it's nothing, gave him a prescription for depression. And he knew something was wrong. And he said, once you get this diagnosis, you'll look back 3 years and you'll realize that there's some of these behaviors and the things that are happening. But she made a joke that that instead of naming his play Dementia Man, that they thought about calling it 6 months. And what he means by this is that when he called the neurologist for an appointment, it was 6 months to wait for the appointment. Then when it was 6 months to wait for the diagnosis. And then the heartbreaking thing was his first diagnosis, the doctor was so busy, he was like, look, I gave you the diagnosis, and literally just left the room. There was no, what do I do next? So a couple of questions are, if we suspect that we have either memory or movement disorder, what are some tips on getting the best diagnosis? And then, a little bit about what the treatment looks like.
Well, step one is always start a conversation first with your primary care doctor. They may have a relationship with a neurologist and be able to get you in sooner, especially if there are, some concerns about safety, right? Everyone's situation is different. Some people live alone. Some people have a lot of good family support or whatever. And everyone's timetable is a little bit different, but definitely start that conversation with the primary care, get the referral. Unfortunately, there are not enough neurologists out there, and certainly not enough memory disorder specialists out there. And so it is hard to get in. Once you get in and you get that initial consult, though, I will say that the follow-up visits are a lot easier to come by, right? And there may be more options if you're open to doing a televideo visit. Like I know with my particular schedule, I have openings for televideo that you can get into a lot sooner than if you were going to see me in person. So, and honestly, that first visit is really about taking a very thorough history and at least getting the tests ordered to get the ball rolling on the workup. And then I usually will tell them, okay, well, let's try to do an in-person visit for your follow-up visit so that I can at least lay eyes on you, do an exam, and make sure we're barking up the right tree. But regardless, these are the first set of, studies or tests I would have been ordering anyway. And those are things like extensive blood work. So I will review whatever blood work they've had in the last 6 months and try to make sure we're not duplicating anything if it's not necessary. Beyond blood work, we usually order something called volumetric MRI. So it's a specialized type of MRI where we're measuring all the parts of the brain, including the hippocampus, which is the memory center of the brain. And this is important because all of our brains, as we get older, they're shrinking, right? It's a part of normal aging, but it also shrinks or gets smaller. There's volume loss in some of these different memory disorders. And so we'd like to know if we're looking at the brain images, if what we see there is appropriate for the age or not. It can give us kind of a look into what's coming down the pike, so to speak, what's coming in your future. So for example, if your hippocampus is measuring way below average for your age, it could be a red flag that something is brewing and something is coming, right? Now, because it's the initial volumetric analysis, most people have not had that done on their brain before. We don't have any study to compare it to. So do I know without certainty that that's what's happening? No, but it gives us a good idea. So that paired with blood work, paired with something called neuropsych testing, which is formal memory testing, we usually can put 2 and 2 together with the information from all these different tests to figure out what's going on. And if we can't figure it out from that set of initial workup, there's more tests that we can delve into in order to kind of get some more information to make a better educated guess about what's going on.
Now, here's, I guess, the truly the good news, bad news, reflecting on some of my Dr. Falconer conversations, is the actual like diagnosis of somebody with Alzheimer's, as you had mentioned, is done at autopsy. I mean, you've got a good idea if somebody has dementia, but that diagnosis is officially, not done at autopsy. Is that still relatively accurate?
Yes, but we do have other ways of getting a better idea. So with the newest drug that just came out that got FDA approved for dementia called lecanemab, or Leqembi is the brand name. It's a monthly IV infusion that removes amyloid from the brain implicated in, Alzheimer's dementia. What we're finding is you got to prove patients have amyloid in the brain, right, to be a candidate for this therapy. And there's a couple ways we can do that. So there is a blood test, although it's highly unreliable, so we don't really order that much, the blood test. But there is something called an amyloid PET scan of the brain that can be done. Although it's not well covered by insurance right now, I'm told that is changing. Some of these larger centers that have amyloid PET scans, there's been a lot of work with Medicare to start these different types of systems for enrolling patients with mild cognitive impairment and dementia, so that you can be on a list. And if you're on this list and enrolled in these different databases, you are supposedly going to be a good candidate to get Medicare to cover this test should you need it. If you want to enroll in one of these IV infusion therapy programs with Leqembi. So anyway, so amyloid PET scan of the brain. And then the other way we can prove that people have amyloid in the brain, which you should not have any amyloid, is to do a lumbar puncture and test your spinal fluid for amyloid. So those are two other ways we can check to see if someone's starting to develop an Alzheimer's type dementia. But as you know, there are many types of dementia. So just because you don't have amyloid doesn't mean you don't have dementia, right? It could be some other type of dementia.
So now on the other side of the equation, movement disorders, Dr. Falconer will, I know he's joking, but he'll say, yeah, I'm going to be helping people with back pain here in a few years because the treatment is progressed. So is the diagnosis and treatment of movement and Parkinson's more accurate? And then the treatment seems to me, and I've seen it with my own eyes, to be fairly good these days for a lot of the different movement conditions.
Yeah, the treatment options for Parkinson's has advanced so much just in the last decade, really. We now have almost, I think it's over 30 medications now to treat Parkinson's. And it's not just the gold standard treatment of carbidopa, levodopa, which, levodopa gets converted to real dopamine in the brain. And Parkinson's, the whole underlying premise and problem of it is, you have a dopamine deficiency. So all of these different drugs in different ways are replacing the dopamine your body's not able to make. But it goes beyond that. We have surgical therapies, and we have some minimally invasive type procedures for Parkinson's. There are so many advanced therapies now that you really can lead almost a completely normal life with Parkinson's, dare I say. And it's true. Yeah, there's even better therapies that are just on the horizon. There were some new drugs that were supposed to be coming out this year. I think, with the FDA, they've gotten pushed back to next year, but those clinical trials have been done. So there's great stuff coming, even beyond what we currently have available to patients.
And then the thing that I've seen, especially with my connection to your center, is the community of people with Parkinson's and movement disorders is amazing. And the exercise classes and the support groups and the things of that nature, like you said, I mean, it's really a very thriving group of people that are all in the same boat and supportive of each other.
Yeah, and that's not just here locally. When I worked in San Diego, they had a very robust Parkinson's community there, a very tight-knit group, and they were all committed to the cause. I mean, if there's a fundraiser, if there's something going on, everybody's involved. And
Mhm.
that is amazing to see that kind of way, the way people pull together for a cause like that. I don't think there's any other conditions out there where there's such a tight knit group. And it must be something about the disease and how it affects patients and their families and the communities that leads to this tight group network. And it's amazing to see people come together for a cause. And nobody deserves it more, for sure.
Yeah.
Because it's this Parkinson's has come such a long way, and it's been through this commitment, not only of people who are involved in the research end of things, but people involved in the community driving it.
Yeah, and I think, and Sonia just dropped something in there about that you all have these educational and exercise resources. I really think these exercise classes, the rock climbing, the music, they're fun things to do that when you get a diagnosis, it's like, oh, that's it. I'm not going to be able to do these things. And seeing these folks come together in many times group or online activities, I think is wonderful. All right, we got a few more questions here. Okay, Edward says, though I might not have serious issues yet, I'm over 60, so I'd like to establish a relationship with a neurologist just to set a baseline or reference point going forward. And as the moderator states, getting a new patient appointment is increasingly hard to do in a timely manner. Is that a bad idea? Man, Edward, I wish, I don't know what Dr. Lawler is going to say about that, but I think that's a great idea because we're living longer, and the longer we live, the chances of, certainly a cognitive and dementia-related disorder increase. But what are your thoughts on that? If, somebody in their 60s, just nothing really going on, but get a baseline checkout.
Well, what probably is happening is something slightly is starting to happen, right? That makes you think maybe I should,
Or
people
it could
have
be family history. It could be
yeah,
like
or family history.
Yeah.
People have fear, and it's not for no reason. People have fear of dementia and getting one of these conditions, and a lot of times it's because of their own family experiences. Seeing someone else go through it can be traumatizing. And so if you have any type of concerns, even if it's a minor one, I suggest coming, because I can't tell you how many times, like I said, people think they're coming to get evaluated for one thing, and then I find something else, right? So it's better to come, establish that baseline, get evaluated, and it's going to take forever to get to see one of us anyway, at least for that initial consult. And then you have that rapport, and it's easier to follow up should things change.
Man, really good plan there, and I like your response. Okay, Louise says, don't the meds for Parkinson's potentially make memory issues worse if someone has Lewy body Parkinson's?
That is definitely not true. So with Lewy body disease, the only difference between that and Parkinson's in terms of how we manage the medications is we initially start with stabilizing cognition and treating any hallucinations that are present. We can't even begin to address the dopamine deficiency until we stabilize the cognitive aspect of things first. And the reason why is because if you start the meds in the wrong order, like let's say we're going to address the dopamine deficiency first, what can happen is you're at higher risk of developing psychosis, hallucinations in a Lewy body patient if you don't stabilize the cognitive aspect of things first. So it's not that the Parkinson's drugs are making the memory worse, but there's a higher incidence of side effects and hallucinations and psychosis if you don't start the medicines in the right order. Yeah.
Okay. And you actually sort of reminded me of a discussion. That question reminded me of a discussion that we had, let's see, back in July. And this woman was diagnosed she was in a nursing home. She was diagnosed with, I believe, Lewy body. She had hallucinations. She had all kinds of things. And she basically was put on hospice. And when she was put on hospice, they took her off all the medications except for pain meds. And she started to bounce back. And now she's living independently in a condo in California. I think what and again, during the discussion, she said she was on 20 meds, but I think what you're addressing is how important, like the sequence of putting somebody on meds and then the quantity of other meds that they have. When you do your initial evaluation of folks, are you finding that folks are sometimes over medicated, and that's what's
Yes.
creating these
Yeah.
symptoms?
I think in most nursing homes, if you were to walk down the hall, you would see most patients are over medicated, right? So they're being given drugs to control behaviors and things like that without anyone really trying to figure out why they're doing what they're doing. And Lewy body patients, I could see how they could easily be over medicated. And if you over medicate a Lewy body patient with the wrong drugs, like let's say you put them on antipsychotics that worsen the underlying dopamine deficiency, you can definitely make things way, way worse when you're trying to make things better. Yeah.
Okay. So, so now you talked about, treating Lewy body. Is there some successful treatments like, where you've seen, a more functional living of somebody with that diagnosis?
Yeah, I mean, I think that depends on when people get diagnosed, like how long have they had it for, right? What other health problems do they have, and how well controlled are those health problems? What is their social situation? Do they have a lot of support, or are they already in, let's say a memory care unit or a nursing home without family? So there's a lot of variables that dictate how well people do. But I do know too, the earlier you can intervene on the psychosis aspect of things, the more successful you'll be at that. There's a 30% increased risk of morbidity and mortality in patients with psychosis and Parkinson's, regardless of what type of Parkinson's it is. So I really have a very low threshold to treat hallucinations. I think I've had this discussion before many, many times on other, lectures and things with patients. Where some physicians don't treat hallucinations unless they're bothersome. But I totally disagree with that, because we know there's a whole trajectory to how hallucinations and psychosis will progress. And initially, it can be something so simple like just the sense of the presence of someone's in the room with you, but nobody is. Or even like you see something out of the corner of your eye, you turn and you look and there's nothing there. It kind of starts like that. And then you may see something, right? An animal or a person, and it quickly fades away. But over time, as it progresses, people lose insight. And what I mean by that is they can't tell anymore if it's real or not. That's when it becomes incredibly hard to treat, right? Because a little bit of paranoia sets in, the distrust for not only family members, but the physician too comes. And then patients are reluctant to take any new medicines, and they don't even want to take the medicines they are used to be taking, So it starts to kind of unravel and spiral out of control. And before we get there, I intervene, right? I want to intervene early because we have great medications to treat hallucinations, whether it's Parkinson's or it's Lewy body. And so, and it takes time for these medicines to start working too. So they may take 6 weeks for the medicine to start working.
6 weeks, there it is.
Yeah, there you go. So you really want to intervene early, even if it's something that's not happening on a daily basis and it's something minor. You want to intervene early. And I mean, certainly you want to make sure it's not happening in the context of something like a urinary tract infection or something like that, right? Chronic acute illness or acute illness like that can certainly bring on hallucinations. But outside of that kind of setting, if it's related to the disease, or even it could be related to a side effect of one of the medicines they're taking, hallucinations is on the side effect profile for every single Parkinson's drug. So you want to make sure that the drugs themselves are not the problem. And people can be taking a medicine for a long period of time and do fine without any side effects, and then a side effect pops up. So just want to make sure that it's not the medication, and a medication adjustment also doesn't need to be made with the regular meds.
Oh, wow. Really, really great information here. And so now I'm looking at the clock and we're getting close to, an hour here. So are there some things that we haven't talked about? I know we've been jumping all over, answering questions and this, that, and the other. Some things that you really like folks to know when they meet with you, whether it be related to memory or movement or both, some things for us to be thinking about?
Well, I think one of the common questions that comes up in initial consults, and it either comes from a patient or it comes from family, is could it be that the symptoms that I'm experiencing or my family member is experiencing is related to normal aging? I get that question all the time, right? And as you get older, patients will say, when I'm talking to my friends or other people who are in my same age bracket, they're complaining of the same stuff. Hey, I misplaced my keys, or that word was on the tip of my tongue. It came to me a few minutes later, but that word finding difficulty, is this the norm? Is this what I should expect as we're getting older? And the truth is, there really isn't a normal amount of memory loss that's expected with aging, right? Usually there's something going on, right? Whether it's your chronic health problems in the background are not completely well controlled. Those can be things like an underlying metabolic problem. You have a thyroid issue, you have diabetes that's not well controlled. Let's say you've got some vitamin deficiencies. Maybe you're not sleeping well at night. Maybe you have a little bit of a mood disorder. You're on medication for depression or anxiety. There's a number of baseline health problems, or let's say you have chronic pain, whether it's a back pain problem or migraines. You may have baseline health problems that can contribute to some memory loss, right? And so it's about teasing through the baseline health problems you have, and are those being addressed or well controlled or not? Or are you starting to develop something more happening that needs to be looked at? So to answer that question that I get almost every single consult is, there isn't really a certain amount of memory loss that's expected to be part of normal aging. There isn't. But today's society, people are on a number of medications. Even medication side effects can lead to this. And so because we're so good at taking care of people now, we have so many different medicines for so many different conditions, and people are living longer and longer with a variety of health conditions. We are seeing this. We're seeing a population of people with multiple health problems on multiple medications, and it's a juggling act, right? And so it's not a surprise to me that we're seeing more and more patients come in with these complaints just because of that, but also because our population is aging. But yeah, no, there isn't a certain amount that I would expect to say, okay, that's normal for 65. Right. That's normal for 70. When in doubt, come and get it checked out.
Yeah. And like listening to Sam Simon talk about who's been diagnosed, and like having a deep conversation with him last week really opened my eyes to a few things, is that because when he describes it, the sort of this fog, I forgot the word that he used, but it was like he felt like he was in this fog, and it was he eloquently describes this in the state in his performance, but it was something radically different. And I think one of the things that I've observed, and I often have conversations about this, when somebody says, "Oh, geez, I misplaced my car keys, senior moment," or "I don't remember somebody's name." One thing to remember, folks, is that I can tell you, actually, like, I had more hard time remembering things when I was in college, okay? Because, and look at our kids. I mean, our kids are forgetting stuff left and right. This is I think a lot of times what we do is we're dealing with some changes in our health or mobility or the sports that we play. And now all of a sudden it's sort of, you forget something, and it's easy to sort of assign that to, this is about growing older. But in the spirit of what Dr. Lawler's saying, and what I heard from Sam Simon is that if you really notice some radical changes, do yourself a favor and get checked out.
Yeah. Today's society too is far different than it was 50 years ago. Think about what we're juggling on a day-to-day basis. It's far more complex. Just look at traffic. There's a lot of things, little stressors that get involved in our daily lives today that we never had to deal with before. So the pandemic is another example of that, how our lives changed with that. So it's just, today's day-to-day life is far different than it was years ago.
And I'm glad you brought up stress, because we've already had somebody ask a question about, or they made a statement that my tremor increases with stress. Is that the stress can do some wacky things to our health. And the last thing that I think we want to see anybody doing is you're stressed about, do I have a cognitive, am I developing a memory disorder or a movement disorder? It's like the best way to solve that is start getting signed up and doing your weight to get in and get a diagnosis, because that'll probably take some of the stress off, regardless of what the answer is. This has really been great, Dr. Lawler. Tell us a little bit about, like, so the your practice is based in Northern Virginia, but I believe you take patients all over the place under certain situations, correct?
Yeah. So, so anybody who is in the state of Virginia could do telemedicine. So even if you're not nearby, right? So we offer telemedicine visits. But my practice is based out of an office that is in the Inova Loudon Hospital. It's like adjacent to the hospital, right there in the Ashburn, Leesburg area. I'm there most days of the week. I am still 1 day a week in the Fairfax Inova neurology office, probably at least through the end of the year, but only on a limited basis. When I first was hired with Inova, they had me primarily working out of that office, which is their like flagship office, until the office in the Leesburg, Ashburn area is being developed and built. So they're building a huge office over there because the need is actually so great. The further you get further west into Virginia, a lot of retirement communities and older populations that really need help. And so Inova smartly has recognized this, and they have expanded access to care out that way. And so by the end of the year, I'm told actually the first part of next year in January is when the new office in Ashburn is going to open. Right now we're in a tiny little temporary office, but we are there and seeing patients almost every day. And anybody can call and make an appointment. And there might be a little bit of a wait, but I think it's worth the wait to get good quality care and get a good initial assessment, and at least get on the right track to figuring out some answers.
Great. And yeah, so I know we get people from all over the place, but if you are in Northern Virginia and if you're a healthcare professional in Northern Virginia, especially, recognize that Dr. Lawler is going to be there in Loudon, and that you've now got this great practice that can help folks with, as we've discovered today, a lot more than movement disorder as well. Yeah, this is fantastic. Bianca says, great information, Dr. Lawler. This has really been a fantastic discussion today. I want to thank you for your time, and folks, will have the recording up so you could share that with your loved ones. I've shared so many of these movement disorders discussions with a lot of people, because what I've found, I've got several people in my circle that there's denial, like, I mean, nowadays I'll run into somebody, since hearing so many of these discussions and seeing what it did to my family, and I'll have a friend that I'll notice a slight tremor on their hand, and I'll say, I don't want you to think that I'm being rude, but I noticed that you have a tremor. Is this something that occurs all the time? And a lot of times the answer is yes. And it's sort of like, I've got this amazing practice that might be able to help you. And it's sort of, oh yeah, if it gets worse, I'll go talk to somebody.
Well, the other thing to remember about that is, you actually don't have to have a tremor at all to have Parkinson's. So you don't have, some people with Parkinson's never develop tremor. So, and this is what I am seeing. People come in for memory complaints, and they're coming in with their walker. They're stooped over, they're having walking problems and balance issues, which they have always chalked up to arthritis and getting older, right? I've got bad knees, I've got a bad back. That's why I'm using the walker.
Yep.
If you're having some gait problems, you're needing to use an assistive device, you should not chalk it up as that's part of getting older, that eventually I'm going to be using a walker or a cane. That's just not true, right? A lot of us have joint problems as we get older, and chronic pain and arthritis and things, but there might be something more going on. Just always remember that. You don't have to have tremor to have Parkinson's.
Great. And Myra says, my sister has both dementia and Parkinson's disease. I plan to give her husband a recording of this presentation today. It's been really helpful. Thanks, Myra. I agree. These are some of the most interesting discussions that I've been a part of, that's for sure. All right, folks. Let's see. So, okay, Sharon, I had the same question, so we're going to stay on here. Sharon asks, so if somebody doesn't have movement disorder, how would they know, or how would you know that they have Parkinson's?
Yeah, I mean, so it happens a couple different ways. One, when you come in, we're going to ask a bunch of screening questions. So there are motor symptoms of Parkinson's and non-motor symptoms, right? Some of the non-motor symptoms start decades before people ever come to a doctor. Things like constipation or a reduction in your sense of smell, right? These are just such non-specific things that think about how many people have constipation or have had constipation in their life. So some of these non-motor symptoms happen decades before people ever get to a doctor complaining of anything, right? So we ask the right questions, and then we do a very thorough exam, right? We have a motor exam. It's called the Unified Parkinson's Disease Rating Scale. So we're going to have you do all these different movements in the office, opening, closing your hands, assessing your tone, watching you walk. We're going to do some distraction techniques to see if we can get a better examination of what your body does naturally. And then we may order a test called the SIN1 skin biopsy test. We can now diagnose Parkinson's just by taking a tiny little sample of your skin, believe it or not. So we have advanced diagnostic tests that we can do to get to the bottom of it.
Okay, great. Well, I'm glad you asked that question because I was wondering the same thing. So, all right, folks. Well, we will see you all. Again, we got a discussion every day of the week this week. So if you're not doing anything for lunch on the East Coast, jump on in and we'll see you there. And Dr. Lawler, again, thanks to you and your whole team over at Inova Movement and Parkinson's Disorder Center. Y'all are doing some great things.
Thanks so much for having me. Happy to be a part of the conversation.